Is there someone who'd like to begin with a question or an example of a difficult conversation that can be brainstormed? Thank you.
Danny Wong from Department of Health. I'd just like to ask you a question that you haven't touched upon explicitly, but could you talk a little bit about subtext and what is unsaid and what doctors understand and what patients understand?
So I think what doctors understand and what patients understand is really different because doctors basically spend all their life in a very sort of technical world, and we assume that everyone understands what we understand. That's a sort of psychological view that explains why conservatives in America think that everyone should be conservative and liberals in America think that everyone should be liberal. We think our view is more common than it really is. And I think the skill that you can use to figure that out is to say, tell me what the other doctors are telling you. What I've now begun doing is saying, tell me what you find when you Google this. Because let's be honest, everybody Googles everything, right? I mean, like your kids now, before they date someone, they'll like Google them to figure out whether they're a creeper or not. It's just amazing. And so I now say, tell me what you find when you look on Google. And it's amazing what people find that is their subcontext to bring this in, that they find about what science can or can't do. They'll say, I read about this mice experiment, and we're just hoping that my dad can get it. And it's sort of like, okay. It helps me out. I then know where I'm starting. Because it used to be in the old days that information sort of rested in the doctor or the doctor and the nurse, the healthcare team. Now information is very democratic. They can get on WebMD and find out as much about their illness and more recent data about their illness than I carry around in my head. And so I need to stop acting like I know everything and be more like a tour guide. I need to sort of figure out what their experience has been in the past, what their experience has been with other people, and then see if I can add a little bit that will help them on this path. Does that answer? Okay.
Anyone with a difficult conversation to offer? Thank you.
I'm a carer for my father, and he asked me, how is he going to know that he's dying?
Sounds like he's really begun to worry about. And that's what I might say. It sounds like you're beginning to really worry about what the end is going to be like. Tell me more about what you're concerned about.
And that's exactly what I did. Luckily, I've had some experience, and I know that the digestive system shuts down. And once I told him that, his anxiety level completely decreased. But it was really about addressing that emotional feeling, addressing his fear, but knowing as a carer how to handle that fear.
Yeah.
It was really just to understand where he was at.
So it's feeling like you had a skill so you could have a conversation that would have been really easy to say, oh, Dad, we're not to that point yet. Don't worry about that, right? Which is what I think many of us do if our parents say, let's talk about my dying. It's sort of like, oh, really, Mom? We don't need to be morbid. And so it's recognizing that you have those skills to sort of sit with their feelings and try to explore what's behind them.
Thank you.
Bob Odette here. I'd be interested in your experience in how advanced care plans or directives help or hinder communications.
So I think that advanced care plans that are checklists, that are do you want X, Y, or Z, are completely unhelpful. First of all, who wants CPR? Have you ever had a patient say to you, regardless of what else happens to me in the hospital, doc, make sure that I get some CPR? Because that's what I really want. And yet, that's how those lists are set up. I want, I don't want. I mean, seriously? It seems to me that they confuse strategy and goals. And so the advanced directives that are really focused on when you think about the future, what are the things that you hope to achieve? When you think about the future, what brings you pleasure or joy? When you think about the future, what do you want to avoid? Those are helpful because then the clinicians can help make suggestions about what to do or what not to do. If it's a conversation about, do you want a feeding tube? I mean, again, not particularly. I might be willing to, though. And it seems to me that one of the things we've done, and this gets back to your context things, doctors and nurses are concerned about the technology that they may have to impose. Patients, it's not really about the technology. It's really about what it's going to mean for their real life, their lived life. And when we talk about the technology, we get these bizarro answers that it's sort of like, my favorite is people who want CPR but they don't want to be intubated. On the checklist it says yes to CPR and no to ventilator, and it's sort of like, oh, we're just going to have respiratory therapists bag them forever. I mean, what's that going to look like? And it's because we've confused strategy and goals. And so I would rather have people talk to their loved ones about big questions, or I'd rather have them tell me about the big questions and just write a paragraph than to fill out checklists that I have no idea what they mean.
We have someone here who's doing advanced care planning. Jackie White, where's Jackie? I thought we just might hear do you mind coming down the front just so it's easier for such a big crowd to see you? Jackie works with Barwon Health. Can you just tell us what you're doing at Barwon Health with advanced care planning?
Sure. At Barwon Health, we've had an advanced care planning program now, probably coming on for about 10 years. And I think certainly taking your point, Robert, it's goal-focused. It's not about checklists and do you want this, do you want that. It's about what's important to you, how do you want things to be into the future, and what do we need to be mindful of when we're actually helping to plan your care into the future.
And you're extending this into the community. Can you just tell us what you're doing?
Sure. We've so the Barwon Health Advanced Care Planning program's been going for a really long time. It's certainly been, they've worked really hard in terms of engaging with GPs so that advanced care planning's happening very, I suppose, in a timely way for people. And from a community palliative care perspective, we're having lots of those goal-focused questions, but we hadn't really been actually finding ways of documenting that so that the conversations that we'd had, actually had a way of flowing through when they needed to be known about.
And so that's why you became so committed to this advanced care planning.
Yeah, and I think I'm a social worker by profession, so I talk a lot and I talk with people a lot. So I guess it's really important from my perspective. I don't know much about CPR, I don't know much about ventilation, but I know a fair bit about actually working with people to work through what their goals are, what's important for them, what's important for their families and their significant others.
Thank you. Thank you very much. A question or an example of a difficult conversation.
Thanks, yeah. I'm Claire O'Callaghan from St Vincent's and Hospital and Cabrini Health, and I just want to reflect on your comment that, if I understood you correctly, that a good death is whatever a family finds meaningful. And I just think we need to be, alongside that, think a bit more critically about perhaps the healthcare context that we've created, leading people to think that deaths are meaningful. And you gave the example of ICU. And I'll tell you about a conversation that left me dumbfounded when I was working in a cancer hospital here. And I'm a music therapist as well as other things, but I was working with a couple of patients for some time. And this particular patient was, in her songs that she was asking, was, connecting in with death-related themes. She was having regular, 5 days a week, radiotherapy. She clearly was at the end of her life. And when she did finally die, her friend in the bed next to her, they'd known each other for some weeks in this hospital, said, well, Mrs. X would be happy because she made her last radiotherapy treatment before she died. I didn't know what to say.
I would have said I'm so glad for her. I mean, guys, it's easy for the palliative care world to have enemies, right? Those silly oncologists, GPs, ICU doctors, they don't get it, they've misguided, they don't, really? They're working as hard as they can. They clearly care about their patients. They're doing the best they can. They have a slightly different reality. Rather than assuming that our reality is the right reality, we'll do a lot better if we're curious about their reality and we try to work assuming the best of them. 15% of the American population are vitalists, which means any life is a good life. If they're in a coma, it's okay as long as they're alive. Now, I personally think that that's just crazy making. It's not my life. If you're a vitalist and you want to do those things, I have no evidence that, that it's wrong. It's just a belief. My job is to help support them through their beliefs, not to be so bloody sure that my beliefs are the beliefs that everybody else should live by, although my children think that that's what I do at home. In my professional job, my job is to walk with people whatever journey and choice they make.
I have a gentleman here.
The use of alternative medications,
Yeah.
in specifically marijuana,
Yeah.
golden seal, bloodroot, and bearberry.
So, it's often the case that doctors, I work in a quaternary care hospital, and the doctors get all crazy making when people who are doing badly on therapies, their families want to bring in other stuff. And I have to say that my view is, look, what we're doing isn't working so good. If you want to bring in, they want to bring in something else. It isn't like what I'm doing is working. Do I think the data supports what they're doing? No, because in a certain sense, I'm a scientist. So there isn't good randomized control data. On the other hand, there isn't good randomized control data. What I have randomized control data for, not doing the job. So if there's something else that's going to give people meaning, why am I going to fight about it? What's the advantage as a healthcare provider of getting into a pissing contest about it? I have to say that for marijuana, I take care of HIV positive patients with pain, and if I got upset about marijuana, I wouldn't have any patients. Now, well, it's true. Now, we ought to be clear about marijuana. It seems to me that in America, where they have medical marijuana, between 8 and 20% of the population, the adult population, is getting prescriptions for medical marijuana. And let us be honest, there is no data to support that. They're basically getting doctors to give them scripts to go get high. They're not doing it because the medical data supports 20% of the population using medical marijuana. There just isn't data. You might believe that it ought to be legalized, then you ought to make that argument. You shouldn't put it on the back of doctors to get into fights about something for which there's no data. And if I was an insurance company, I wouldn't pay for it except for the 5 or 6 things for which there's good data. That doesn't mean that people can't go and do it on their own. Whether it ought to be legalized or not is not something that you want to hear my view about, because I don't know.
Thank you. Another question or a comment. I'll just come down the other end, Odette, and I'll come back to you in a moment.
She just gets her exercise like this.
I'll come to the rear in a minute. Thank you.
Yeah, she's gonna fall.
Okay. Thank you, Robert, for your information this morning. It's great. Chris Dorr from Yarrawonga. Just a question about the family that says, and Dad is obviously dying in the next 24 hours. We don't want him to know. We don't want him to know he's got cancer. We don't want him to know he's dying.
So can I ask you a question? Why did the family get this information before the patient?
Yeah, personally, I think the patient knows.
Well, so this is happening because we screwed up.
Yeah.
Okay, that's point one. The second is, why is this family saying, we don't want you to tell him? Let's brainstorm. What are the options? They're really sad and can't cope. They're afraid that you're going to tell them the way that they got told, which was really pretty horrible. What else? They have cultural beliefs, and the patient has those cultural beliefs. What else? They may know the patient better than we do. What else? They don't want to distress him. It's their dad. Why would they want to make their dad sad? So the first thing to say is, I can see how hard this is for you. Tell me more about why you're so worried about giving your dad the information. Then it's like doing a little reality checking with them because they're emotional. Your dad seems pretty smart. Do you think he wonders why the kids have all come from Tasmania and New Zealand? Well, seriously? And you're all in there like with red eyes and... So I don't, all I do is just raise it. I wonder what your dad's thinking. And if your dad doesn't want to know, trust me, I don't want to tell your dad anything he doesn't want to know. And yet if your dad says that he wants to hear things, he may have things that he needs to say to you. So would it be okay if I say to your dad, some people want to hear everything about what's going on with their illness. Other people would really just rather I talk to their kids. Tell me which kind of person you are. And most families are fine with that. And I'm fine with that. If they say go talk to my kids, it's like, okay. I shouldn't assume that they have known their dad for like their entire lives and I've known him for like 3 hours or a week or a year, that I better know what their dad needs. So I need to slow down, not get into a pissing contest with them about, well, you know your dad has the right to know. Like, really? That, and the best is when people say, well, morally, I have to tell your dad, which is like you're an immoral person because you don't want your dad to know. It just seems to me that those kinds of things are just, you're trying to get into a fight to get into a fight. If you assume that they love their dad and they care about their dad, and acknowledge it and slow it down, my sort of view is that 95% of the time, these conversations go away. Yeah.
We'll continue to have difficult conversations while we refuse or we fudge the language that we use. And as health professionals, I see it on a daily basis. I think we need to take responsibility for that. And I think we need to continue to educate the media, the community. It's okay to talk about death and dying. People will not open up to us if they're feeling blocked. And as a social worker, that's part of my job to encourage that communication. But I work with one of the best oncologists ever. And when I see how she operates with dying patients, and they will ask her because they trust her and they know she'll talk about it, compared to other lovely oncologists can't do it. I find that really frustrating pretty much on a daily working basis.
So 3 things. First is some people want to talk about it, some people don't want to talk about it. My mother-in-law, who died of ovarian cancer, talked about death and dying for about 10 minutes in her last year of life. She sort of did everything right. She moved in with us. She stopped doing chemotherapy. She got hospice nurses because they were such sweet ladies. She started a microbiotic diet because it might work, and the day before she died, she wouldn't eat a Krispy Kreme donut because you never knew when the diet was going to kick in. No, seriously. Her view was there was nothing gained to talk about it. She didn't want to, she was going to live her life. It wasn't something she was going to talk about. It's okay. Some people want to talk about it, some people don't want to talk about it. Second, there's a certain sense in which we make it worse because we've made science the new religion, and we talk about, your papers all talk about medical miracles and the cure that they cured 7 rats of some disease, and it'll be out from humans in 23 years, and so everyone gets excited about it. We need to be really careful that if our press pushes science that always has new things, we shouldn't be then surprised when people come in and want those new things. And it will take it'll take a cultural change to sort of say that we've had a lot of people on this earth and none of them are still living, to begin to talk about the fact that it's just the sort of way things work. And in America, because we have football, which is real football, not that soccery thing. I know. So I've now begun talking to my 90-year-olds and I say, it's the fourth quarter. And the way we play the first quarter is different than the way we play the fourth quarter. So I just want to talk with you to make sure that we talk about what the fourth quarter should be like. And if they don't like football, we talk about plays. There are 3 acts. We're in the last 5 minutes of the third act. And what you do in the last 5 minutes of the third act is different than what you do in the beginning of the play. And so I think you're absolutely right, but it's going to take a much bigger non-healthcare provider cultural view that involves, I think, the press to a large degree, talking about not being so excited about every new scientific advance. Because what we basically do is we give people messages that it's all optional. Besides the fact, I don't know anybody that really wants to live to 120 in a 120-year-old's body, really, seriously? I mean, even if you could live to 120, at a certain point, the wheels start coming off. I mean, if you could live to 120 in a 30-year-old's body, that'd be one thing, but...
Kat Swift, where's Kat? I'll come over to you, Kat, and then I'll come to you, madam. I think you put your hand up. Where are you, Kat? We'll just wiggle through. I just want... Sorry, guys. Here, maybe we'll stand in this corridor. It'll be easier. Kat, can you stand up and just introduce yourself to everyone? Come down the front. I don't mean to intimidate people, but it's better when you can see her face.
Some may not think so. My name's Kat Swift. I work at the West Gippsland Healthcare Group, which is the hospital basically in Warrigal. I'm a social worker there and I work 1 day a week in the palliative care service.
And why I asked you to come up now was that focus on speaking to people where they're at, that everyone's different, that Robert was just talking about, because that's very much your experience, isn't it?
Yeah, communication's been one of my pet projects all my working life. I'm really into communication. So what you're talking about, Robert, is sort of communication 101, and I hope everybody takes that on, because it really makes a difference, and not only to your patients, to your children and your husbands too, if you use the same techniques. And
how many husbands have you got?
Your wives. I lost mine. Not to death.
Listen, I know that you made a video.
Does that mean you lost him and then you tried not to find him? Yeah, okay.
I know that you made a video as part of training for volunteers. Can you tell us about it, the approach to it?
Yes. I was asked to talk to the volunteers, existing volunteers, about communication skills, a review program. And I thought, oh, the poor things, going over the same ground over again, reflective listening and, all the things we've been talking about today. And I thought, how can you make it a bit more exciting, a bit more fun, a bit more interesting? So I've got a bit of an alter ego. You'll see a photo of her out on the poster out there. Her name's Myrtle Cardigan, and her husband's name is Cable Cardigan. And we decided to make a movie. So the volunteer coordinator loved doing movies, and I've got a young friend who's a little actress, so she became the woman that the volunteer was visiting, and Myrtle Cardigan went off to visit the woman who needed some help through the palliative care service. And what she did was interact with the bereaved woman, in the worst possible way. And the purpose of that was to help the volunteers see what knowledge they already had. So what we did after that was we showed it to the volunteers in the training, and they had a good giggle, and then we dissected what Myrtle Cardigan did, and what mistakes she really did make, and what you shouldn't do. And what it did for them is it gave them a sense that they actually knew what they were talking about. So it valued what they already knew, rather than just going over the same ground and making them feel, well, we all know this sort of stuff.
Is it possible for this mob to see Myrtle Cardigan? Like, is it on YouTube or something like that?
No, she's not. She has been around in different places. But you can see her out on the poster if you want to see Myrtle. She's looking lovely out there.
Okay, well, thank you so much. Thank you. Could you give Kat a round of applause? I just had a lady here and then I'll come to you.
Catherine from Eastern Palliative Care. One of the difficult conversations I think I've had recently related to misinformation from two health professionals, and one that was highly respected by the client that told the family that this particular person would need an IV at the end of life because dying of dehydration was horrendous. And I think sometimes you find yourself in those positions where you understand that that client respects that specialist very much so, and how do you have a conversation around perhaps suggesting that what they've been told by somebody that they've had 12 months involvement with is perhaps not correct?
So it seems to me that in those situations that I wouldn't try to tell them it's not correct. I'd call up the consultant, the person who said it, and said, hey, the family really respects you, and I'm not sure what you told them because I don't know what they got told. All I know is what the family heard. So I just want to check in with you. And then I say, would it be okay if I shared our experience? And see if they're willing to go back with me. Because the worst thing you can do for this family is to get them to sort of be whiplashed by the fact that different healthcare providers have different views. And it's really easy for us to be mad at other people who don't do it the way we do. And the question I would continually ask you guys is, what can you do to make it better, given that the other people are going to be other people who aren't going to do it the way you do? In this case, I would say, oh my God, that sounds like you just really want your loved one to be comfortable. Would it be okay if I called the doctor and touch base with them? That seems to me that I should make my change that way, rather than say, well, he was confused. Or he was smoking that pot that other guy was talking about. So I don't assume that that's what the other doctor said. Because how many times have people said that you said stuff where you didn't really say it? So just say, isn't that interesting? Because he seems to be a really good doctor and seems to be up to date, and he clearly cares, or she clearly cares. I guess I should call up and sort of figure it out. Because maybe they just have a really different experience.
But isn't this partly a cultural issue within the world of the healthcare system? Like, it's my understanding the World Health Organization has only just recently made a statement about the integration of palliative care into the health framework. I think there's reference to it in our materials. So for a conference like this is still a group who are wanting to, to advocate for family and patient choice, where they would feel on occasion they do observe clinicians that don't involve palliative care because palliative care is not yet truly integrated into the health system.
So part of this is that there's never going to, subspecialist palliative care is never going to take care of the people of Australia. There are never going to be enough subspecialist palliative care clinicians to take care of all people with serious illness. It just isn't going to happen. In America, there's a 16,000 person shortage, and we graduate between 150 and 200 new palliative care physicians a year. Just do the math. It doesn't work. It's only going to work if we assume that everybody wants to do a good job and we try to help them get better in a loving and kind way. because that's the only way they will get better. If, the oncologists think that you always think that they're a bunch of idiots who give too much chemotherapy, who wants to talk to somebody who thinks that you're an idiot? It's got to be, I want to help them. I trust that they care about their patients, and we need together come up with a solution. Because the data suggests that they can get better, where that means that they can attend to emotions, they can be taught to do this, and we can learn more about oncology because that literature is changing as well. I just think that it doesn't do us any good to sort of have boogeyman's.
Could I just quickly tell people who want to tweet what the hashtag is? If you're into this, it's hashtag PCVConf, C-O-N-F, 14. Hashtag PCVCONF 14. And now I have a question here.
Thank you. I've got to first say, it's so lovely to sitting beside Julie Cross. Oh my God, so exciting. I just needed to say that out loud. I feel so much better. I sit with Myrtle. I'm a communicator from way back. And I'm also now looking at trying to put in some of end-of-life care studies into a very large tertiary acute hospital that doesn't have palliative care. So working with nurses recently, it's interesting because everything is so task-orientated. It's incrementally task-orientated. And inviting them into a humanistic phrase of, well, you're actually still working with your people who are in a bed. You still have an opportunity to do those lovely things that you described. But I think it's giving people permission to be human and connect at another human level with someone who's in a bed, and noticing and becoming much more alert and awake to the missed opportunities to actually engage in this emotional human conversation. But I think the other thing in these 40-odd nurses that I've worked with very recently is, it's okay to stuff up, it's okay to be human, but it's not okay to not miss that opportunity. And if that means you practice, and you sit in the tea room and you have practice at being able to engage in these conversations, then do that. Because I think our people who are in our acute hospitals, who don't have the luxury of having access to good clinicians, it's very frightening for them. And it's not rocket science, and it doesn't take a long time. You can have a very meaningful conversation in a short space of time. Just that thing, tell me more, is a beautiful thing to be able to say to someone. And the other thing for me is, one of the critical things is being able to say to someone, it's okay, take your time.
Mm-hmm.
Thank you.
So can I make one small, I think if you're going to get better, you're not going to try it all the time at the beginning. If all the literature on expertise says that the way to get better is to try one thing in a setting where you're likely to succeed, to do it, to reflect on it, and try it again. That is, I tell my house staff, you don't have to try these skills all the time. If you try to do it all the time, because at the beginning it's really slow to do it. It feels artificial to do it. So don't do it on a crazy day where your significant other yelled at you and you have to be done at a certain time. In those days, just do what you normally do. Try it twice a day. Just try to attend to an emotion twice a day and reflect for 5 minutes how it went, and then try again the next day for twice a day. And as you get more capacity, you'll find that it gets easier and you can add another skill. Do any of you play tennis? No? Are there any sports that the people here play? How, swimming? Yeah, swimming, good. When you learn how to swim, you learn one stroke at a time. And you practice it over and over and over again. And so there's a certain sense that my recommendation for you and for the people you're trying to teach is help them succeed. If you try to have them do everything at once, they won't succeed. They need to be kind to themselves as they're learning new skills.
Thank you. My name's Sandy May. I'm interested in the notion of people's perception of what is suffering. I'm talking in terms of the final hours of someone's life, where you've got orders given, but certain staff might interpret orders a certain way and other staff might interpret them another way. Now, I know you spoke about multiple realities and our version of what is the truth might be different. We can't always fix it. We can't make other people feel the way we do. But when you've got an advanced care plan where family have said, we're not afraid of the use of opiates, in fact, we want maximum symptom management for our mother. We do not want our mother to suffer. And then I've seen that some of my staff, in my opinion, have undergiven what should be given. I find it extremely difficult sometimes with someone on almost equal footing with me to say to them, why have you given such a small dose? Because I know they will say to me, but they're perfectly comfortable. Now, it's this nexus, it's this thing that happens when you look at a patient and one of you might think, no, they're not comfortable. I could make that person more comfortable within the context of what the family wanted, within the legal context of the orders given, that other person has had a completely different thought. And I know from experience that kind of mentality on the part of others can lead to people chain-stoking, choking, coughing, and dying, say, for about 1 or 2 days longer than they needed to. Has anyone ever seen anything like that?
So I'm going to try to give you a way to deal with that. Because let's assume the family's not there, because my view is that if the family's there, it's the family's perception of suffering. It's not mine, it's not yours, it's the family's perception. So assume there are these two nurses. And nurse 1 says, he's suffering, why aren't you giving him more opiates? And nurse 2 says, no, he's not, he's completely comfortable. What should nurse 1 say? Yes, he is. No, he's not. Yes, he is. What should nurse 1 say to get off that?
What is it about how he is that makes you feel he's completely comfortable?
So I'm going to try to revise it a little bit, because if I say, what do you see that makes you think? I might feel like you're challenging.
Yeah, okay.
I might say, clearly we have a different view. Help me understand.
Yeah, tell me more.
Help me understand, because I'm seeing stuff different than you. That is, suffering is a conclusion. We need to get away from the conclusion and get to the data. That is, what's the data for suffering? He's frowning. He's breathing 40 times a minute. He's tachycardic. He's alive, so he must be suffering. Well, again, I just want to know what the data is, because then we can have a conversation. If he's breathing 40 times a minute, I'll say, when I try to breathe 40 times a minute, I feel uncomfortable. So I'm assuming, because in fact he's unconscious, we have no way of knowing if he's suffering or not. I assume he's uncomfortable. And then I wait to get a response. I try to look at the data, not at conclusions. Because if we have a conversation about conclusions where it's like, I like chocolate, I don't like chocolate, what is there to say? Let's talk about what we see and experience. And then let's talk respectfully about the worries they have about opiates. Because, in fact, given how little education they have about them, in fact, they call them narcotics, which are what the police call them, I shouldn't be surprised. And I should say, maybe I need to bring some articles in about the real effect of opiates at the end of people's lives and not really, in fact, shortening life expectancy. Because they're trying to do a good job and they want to try to diminish their suffering. It isn't like any nurse says, well, I never liked the patient in 302. Let's let them suffer a little more. They're doing the best they can. So the question for me is, how can I be open and respectful and try to explore it in the same way that I want them to treat the patient and the family? And I think it's really hard, because I'm as sure I'm right as anybody else, right? And it's hard not to say, oh my God, he looks like he's really uncomfortable. Why aren't we giving him more opiates? And the minute I say that, I've set up the other person to say, no, he's not, because what I've done is I've criticized them. And that isn't going to get, it's not going to get either of us anywhere, and it's clearly not going to help the patient.
Kerry Noonan, where are you? I thought we've just got a moment left of this session. Is Kerry here? Can you hurtle down the front for me? Kerry...
This is just like The Price is Right.
I wish I had more prizes. Kerry's the director of the Groundswell project, and tell them about what's happening on the 8th of August.
Well, the 8th of August is Dying to Know Day, which is really about community conversation and what Robert was just talking about, that grassroots approach to having these conversations.
Let's get your props so that you can promote them. Thanks a lot. Do you want to...
Well, some of our wares are in the coffin outside.
There are, in fact, 2 coffins outside. It's the plywood one, not the raffia one.
So there are some posters out there, but also some cards. I mean, one of the things that we talk about is death literacy, which is really about, and we believe one of the ways, and some of the research that we've done at the University of Western Sydney has shown that one of the ways to develop death literacy is to actually be included in caring, to include more of our families in these conversations while death is happening, while dying is happening. And then those people actually become advocates that can take those conversations back out into the community and actually then use that knowledge next time they need to care for someone who's dying. So Dying to Know Day is really about developing that ripple effect, and I know that there are heaps of people here who are running events next Friday, but there are 47 already across the country.
Look, thank you very much, and if you want to get information, just have a look inside the coffins. I guess, Robert, I'm wondering what the link is between that kind of community advocacy and then the capacity of people to talk when it's their own family member. Do you think that sort of systemic work can assist in what you're advocating for?
Yeah, I think to a certain extent that, you know, the data suggests that most people at the end of their life, in the weeks or months, in fact, lose capacity. And so often their families are very involved in trying to make decisions that they would have wanted, and all the data suggests that's easier if they've had a discussion with their loved one. And so if they have a capacity to begin to talk about these issues in a way and not just say, oh, Mom, don't worry about it, I think it's going to make it easier then for the healthcare providers to talk about the issue. Because if this is a culture change project, there's never been a culture change in medicine that medicine has driven. It's always driven from outside of medicine. And so if it is going to be the case that dying that is respectful of patients' values is going to change medicine in the same way that childbirth changed, childbirth didn't change because the OBGYNs got together and said, oh, we ought to listen to women. It changed because of the women's movement. And it isn't going to change. The care of people who are seriously ill isn't going to change because the medical establishment, which is pretty, conservative, says we need to change. It's going to change because of outside forces. And so to a certain degree, if we don't push those outside forces, and that's the patients and families who either have loved ones who have serious illnesses or are likely in the future to have one, it's never going to really be a culture change that works.
Well, Robert's going to join us for a panel tomorrow, but would you please thank him warmly for his contribution now?